Hi, my name's Sarah Polak and I'm a lecturer at the London School of Hygiene and Tropical Medicine. So in this session today we're going to be looking at rapid assessments in eye care. And by the end of this session you should be able to appraise the strengths and the weaknesses of rapid survey methodology used within eye care, and also understand how the results from rapid surveys are utilised to develop eye care programmes. So let's start by reminding ourselves about why we need to do population-based prevalence surveys within eye care. Well, these surveys provide data on the prevalence and the causes of visual impairment. And this information is really important for a number of reasons. Firstly, it's important for helping to plan services and eye care programs. So knowing how many people are visually impaired or blind and what the causes are and who within a population are particularly affected enables programs to determine what services or interventions are needed for who and for how many. Secondly, if surveys in a given area are repeated over time, then this enables progress or change to be monitored over time. And thirdly, these data are really important for advocacy to help mobilise resources to support eye care programmes. So in an ideal world where resources were not limited, we, in our dream survey scenario, would undertake very detailed large-scale detailed ophthalmic surveys. For example, we would conduct national surveys such as the one in Nigeria. Our ideal surveys might include very detailed eye examinations using sophisticated equipment and highly trained ophthalmic personnel to accurately diagnose all different types of eye conditions. We would also include all ages. However, while these surveys generate detailed information, they're extremely expensive and resource intensive, and therefore just not a realistic option in most places. So rapid surveys provide an alternative methodology. There are a number of different rapid survey methodologies for eye care, but they have a number of features in common. Firstly, they tend to use simplified eye examinations that can be undertaken by local personnel and with locally available resources and equipment. They use fairly straightforward but epidemiologically sound sampling techniques. And the analysis of the data from the surveys is quick and easy to interpret. They're typically carried out at district level with the aim of informing and being used for the planning of district level eye care services. So in this session we're going to look at two examples of population-based prevalence surveys that can be undertaken relatively rapidly to inform eye care programmes. So firstly, the rapid assessment of avoidable blindness, or RAAB. So more than 200 of these surveys have been carried out throughout Africa, Asia, Middle East and Latin America. RAABs aim to assess the prevalence and the causes of visual impairment and blindness in people aged over 50 years. They also collect a number of pieces of information on cataract, given that this is the leading cause of blindness in this age group. So RAABs assess cataract surgical coverage, the visual outcome from cataract surgery among people who have been operated, and the barriers to accessing cataract surgery. And all this data is collected for people aged over 50 years and typically at district level. So just to give an overview of the RAAB methodology. Firstly, obviously we can't include everybody in a district in a survey. That would be far too time consuming, and therefore we have to sample people from the population. And this sampling takes place in two different stages. Firstly, clusters, which are population units such as villages, are selected using a method called probability proportionate to size sampling. Secondly, within these clusters, households are selected using a method called compact segment sampling, so that in each cluster 50 people aged over 50 years are included. So the survey team within each cluster go door to door to identify 50 people aged 50 years and above. Each identified participant has their visual acuity tested using a simplified Snellen E-chart. This tells us who has visual impairment and the level of severity of their visual impairment. Any participant who's found to have visual impairment undergoes an eye examination to assess the cause of that visual impairment. And finally, there is an automated data entry and analysis package, so the data from the RAAB are quickly available. RAABs typically take between about 4 to 10 weeks to undertake, with 3 to 5 teams, each consisting of either an ophthalmologist or an ophthalmic resident, an assistant and a driver. So RAABs are relatively rapid and therefore relatively affordable to undertake, and they're rapid for 3 key reasons. Firstly, because they focus on people aged over 50 years, and it's in this age group where the prevalence of visual impairment is by far, and blindness is by far the highest, and that therefore minimises the sample size required for the survey. Secondly, it uses simplified eye examination techniques. This is sufficient for diagnosing the leading causes of avoidable blindness, which are prioritised by Vision 2020, but diagnosis of the back of the eye diseases using these methods may not always be very accurate. And thirdly, there is an automated data entry and analysis package for RAAB, so the results from the survey are quickly available. So what do RAABs tell us, and how can they be used for planning of eye care services? Well, firstly, RAAB estimates the prevalence of visual impairment and blindness and tells us what the main causes are. This can be used to prioritise areas for action and highlight what services are needed. And this in turn can feed into the district level eye care action plans. So for example, in a survey in Chiapas in Mexico, the leading causes of blindness were cataract, diabetic retinopathy and glaucoma. RAAB also gives a number of important pieces of information on cataract, which can guide cataract services in the area. The information collected can be used to estimate the number of cataract operations that need to be performed per year in order to help everyone who needs cataract surgery. Secondly, information is collected on the number of people who have already undergone cataract surgery, and this can be used to estimate the cataract surgical coverage, which is a measure of progress. Thirdly, where no hospital data are available, the RAAB survey findings about the visual acuity for people who have undergone cataract surgery can be used to give an overview of the quality of the cataract surgical services. The causes of poor visual acuity can also be used to identify areas for improvement. For example, if poor outcome after cataract surgery is common and is attributable largely to refractive error, then better optometry services may be needed. Finally, people within RAAB are asked, people who have cataract and have not undergone cataract surgery are asked why they have not been for surgery. And this tells us the main barriers that need to be overcome when providing cataract services in an area. For example, if awareness of services or lack of awareness of services is the main barrier, a publicity campaign to help overcome this may be needed. So RAAB provides important data to inform eye care programs, and because it's relatively rapid and affordable, it can be repeated after, say, 5 to 10 years, which can help to monitor progress. However, RAAB is not a detailed blindness survey, and therefore it does have a number of limitations. So while RAAB provides a reasonably accurate estimate of the prevalence of blindness and the proportion of that blindness which is avoidable, it's not designed to give accurate estimates of the prevalence of specific causes of visual impairment and blindness. Further, because it uses simplified examination techniques, it doesn't accurately measure back of the eye diseases such as glaucoma or macular degeneration in detail. And thirdly, because RAAB only focuses on people aged over 50 years and above, it does not provide data on childhood blindness or people less than 50. And further, the survey itself does not plan eye care programs. So it's really important that RAABs are accompanied by a situational analysis of the local eye care services, and that the results are disseminated to the relevant stakeholders, and that this information is used for planning. There is no point in undertaking a survey, and yes, unless it's going to be used for this aim. There are also several variations on the RAAB methodology that have been developed to collect additional data on specific eye conditions. These include diabetic retinopathy, refractive errors, and presbyopia. So RAAB assesses the prevalence and causes of visual impairment and blindness, but rapid methods also exist for specific eye conditions such as trachoma. Trachoma is an infection of the eye caused by the organism Chlamydia trachomatis. Repeated and untreated infections with trachoma can eventually lead to blindness. This happens because repeated infections can lead to scarring of the eyelid and eventually interning of the eyelids, causing the eyelashes to rub on the front of the eye. This in turn causes the cornea to become scarred and can lead to vision loss if not treated. Trachoma is found in poor rural communities typically throughout Africa, Asia, Middle East and Latin America, as this map shows, and typically occurs where people live in overcrowded conditions and where there is poor sanitation and limited access to water. There is a well-established and WHO-endorsed trachoma control strategy known as SAFE, and SAFE stands for surgery to treat the interned eyelids, known as trichiasis, antibiotics to treat the active infection with the organism that causes trachoma, and facial cleanliness and environmental improvement to prevent the transmission or reduce the transmission of the disease. Now, the implementation of SAFE and guidance on where SAFE needs to be implemented is very much dependent on what the district level prevalence of trachoma is needed. So district level prevalence data is key for planning trachoma control. Although trachoma is known to be endemic in more than 50 countries, data were lacking for many of the suspected endemic areas. And in response to this, an initiative called the Global Trachoma Mapping Project is underway to map all those remaining suspected endemic trachoma areas in order to inform where SAFE needs to be implemented. To achieve this, a relatively rapid population-based prevalence survey methodology has been developed for trachoma. This survey collects data on the prevalence of trachoma and also on hygiene indicators, such as the safe disposal of human feces and access to water for use for personal hygiene. And similarly to RAAB, the data is collected at district level in order to be able to inform district level trachoma control efforts. So as for RAAB, the sample is selected in two stages. Firstly, clusters throughout the target district are selected at a minimum of 20. And secondly, households within clusters are selected. And this is a minimum of 30 households are selected, which is the number of households that it's reasonably expected one team can visit in one day. So within the selected households, all residents aged over 1 year are examined to assess for the presence or absence of the signs of trachoma. And this examination is done using a simplified grading scheme. Questions are also asked about water, sanitation and hygiene indicators. And the data are collected electronically using a smartphone. And the analysis is automatic. So the results from the survey are available very, very quickly. So this population-based trachoma prevalence survey tells us about the prevalence of trachoma and also information on hygiene indicators. And this is collected at district level. And this information is then used to guide the SAFE implementation. For example, in populations with trachoma prevalence in children aged 1 to 9-year-olds of over 30%, WHO recommends that the SAFE strategy is implemented for at least 5 years before the prevalence is assessed again. So prevalence data are key for making decisions about what elements of the SAFE strategy should be implemented for how long. So to summarise, while large-scale detailed ophthalmic prevalence surveys provide rich information on different eye conditions, they are prohibitively expensive in most places. Rapid survey methodologies provide an alternative. These surveys typically use simplified eye examination techniques, which means they can use local staff and resources, although this does limit the level of detail that can be collected about some eye conditions, and that needs to be taken into consideration. The analysis of the data is automated, so that results are provided quickly, and the surveys in total are undertaken in a relatively short amount of time. Surveys are undertaken at district level typically, so that they can be used for the planning of eye care services. Thank you very much for your time and attention.